Okay, this recording is on ECG and lab values for March 13th, Friday. This is not my favorite topic, so I'm not really going to go in depth on this. This is kind of just, for me, it's going to be like a surface thing that I'm going to need to come back and revisit over and over and over again before I take this NPTE. But so anyway, these are the PDF pages that he posted in the file. They use the 6th edition. I use the 7th. And so I posted a lot more pages than what he did, I think. He hops around a lot. But anyway, let's go ahead and we will start the readings. So this external speaker is still on.
Page 476. Laboratories values when managing patients with heart disease. Certain laboratories values are particularly important. Table 13.2 provides reference values for various laboratories tests. The hemoglobin and hematocrit levels depict the oxygen carrying capacity within the system. Each gram of hemoglobin carries approximately 1.34 millimeters of oxygen within arterial blood. A normal hemoglobin level is approximately 12 to 14 g/100 ml of blood in adult males and 14 to 16 g/100 ml of blood in adult women. For example, for a hemoglobin level of 15 g/100 ml of blood, the oxygen carrying capacity is approximately 20 millimeters O2/100 ml of blood. 15 x 1.34 equals 20. Now, if we consider a patient with a hemoglobin level reduced to 7.5 g/100 ml of blood, the oxygen carrying capacity is reduced by half and is approximately 10 millimeters of O2, 100 milliliters of blood. With reduced oxygen carrying capacity, the heart must work harder to compensate for low oxygen levels to provide sufficient oxygen to the peripheral tissue. During heart failure, increased workload placed on a failing heart will exacerbate failure. A general rule of thumb is to use caution and lower the intensity when exercising patients with cardiovascular disease and hemoglobin levels less than 8 g/100 ml of blood. Electrolyte levels are also important to consider before treating patients with heart disease. Appropriate levels of potassium, calcium, and magnesium allow for normal electrical conduction through the heart. Hyperkalemia, low potassium, usually less than 3.5 mg, produces arrhythmias with flattened T waves and depressed ST segments, as well as bilateral lower extremity muscle cramping. An inverted U wave may also be noticed on the electrocardiogram. Hypercalcemia, low blood serum calcium levels, and hypomagnesemia, low magnesium in blood, have the potential of increasing ventricular ectopy within the heart. In addition, calcium enhances contractile function of muscle cells. Patients with hypercalcemia have reduced cardiac contractility, whereas those with hypercalcemia present with erratic heartbeats. Renal function tests are done to determine kidney function and examine blood urea nitrogen, BUN, and creatinine levels. These levels are especially important to review in patients with heart failure and patients prescribed with diuretics. Finally, many patients with heart disease also have diabetes, and therefore it is important to review blood glucose levels before exercise. Page 484. Evaluation of patients with acute coronary syndrome, the evaluation triad. In addition to the history taking and review of systems, the evaluation of patients with ACS places emphasis on three major components: evaluating patient complaints, ECG changes, and cardiac enzyme levels. Figure 13.9. The following reviews each component. Patient complaints. In ACS, most patients with myocardial ischemia will present with classic chest pain referred to as angina pectoris. Classic angina pectoris is diffuse and retroexternal and described as a pressure, heaviness, tightness, or constriction in the center or left of the chest. Pain is usually precipitated by exertion and relieved by rests. 30. It is important for therapists to evaluate factors that provoke chest pain. These may include activities that increase myocardial oxygen demand, including physical activity, cold, emotional stress, sexual intercourse, meals or lying down in the supine position, which results in an increase in venous return and increase in myocardial wall stress. 31. The patient usually often reports an intense pressure like an elephant sitting on the chest. Further, angina may present as a referred pain due to involvement of a neural reflex pathway via the thoracic and cervical nerves. This results in chest pain not being felt in a specific spot, but usually is a diffuse discomfort that may be difficult to localize. It may radiate to anywhere in the upper extremities and thorax, most specifically to the left arm and left jaw. Figure 13.10 delineates common areas for referred patterns of chest pain. The hallmark approach to differentially diagnosing ischemic chest pain from non-ischemic chest pain is to observe for accompanying signs and symptoms of compromised cardiac output. 31. These signs include dizziness, lightheadedness, weakness, diaphoresis, sweating, fatigue, and weakness. Thus, cardiac chest pain during ischemia or an infarction will be accompanied by signs of compromised CO. The chest pain from other etiologies including pulmonary chest pain, pleural pain, gastrointestinal-related chest pain or musculoskeletal pain of the thorax will not precipitate the classic signs and symptoms of compromised cardiac output. 31. ECG changes in AXMIs are identified by 12-lead ECG findings. 32. The ECG, also referred to as EKG, is used to examine nature, rhythm, conduction delays, and coronary perfusion. Two of the most common types of ECG are the single-lead and the 12-lead ECG. Figure 13.11. In the single-lead ECG, only one area of the heart, for example, anterior, lateral, or inferior, may be viewed at a time. This area may be changed, however, by altering the location of the electrodes. In the 12-lead ECG, 12 areas are viewed. The single-lead ECG is sensitive to rate and rhythm changes and is commonly used for monitoring patients during ambulation and activity. Continuous monitoring is accomplished either via telemetry, radio transmission, allowing the patient freedom to move around when wearing this portable device, or by hardwire, where the patient is attached to the monitor by a cable approximately 15 feet long, therefore limiting mobility. A variation of the single-lead ECG is the 3-lead ECG, which is usually hardwired and is used for monitoring in an inpatient setting. It can be worn continuously throughout an entire treatment session or throughout the entire hospitalization. Unlike the single-lead or 3-lead system, the 12-lead ECG does not provide continuous monitoring, except during an exercise tolerance tests, ETT, completed on a treadmill or stationary bicycle ergometer. Two common uses for the 12-lead ECG are the resting ECG taken with the patient quietly supine and ETT. 12-lead ECGs are invaluable in identifying perfusion impairments in the coronary arteries and in assisting with arrhythmia detection. During the ETT, the ECG is continuously monitored to determine the presence of ischemia or arrhythmias with each increase. In workload, the 12-lead ECG is sensitive to changes in perfusion as well as rate, rhythm, and conduction. Each coronary artery is represented by a cluster of leads that, although not absolutely correlated with each individual's anatomy, gives a general schema for myocardial perfusion. During the examination of a 12-lead ECG, the ST segment is clinically useful in identifying the presence of impaired coronary perfusion, either ischemia or injury. 32. The J point, the point where the S wave turns into the ST segment, the point of reference for interpreting the ST segment. 32. If ischemia is present, the ST segment will be depressed, 1 or 2 small boxes, at 2 small boxes beyond the J point, and the T wave may also be inverted flipped. Ischemic changes will be present only while the ischemia is present. When the ischemia has resolved, the ECG will return to normal. 32. Conversely, a large acute MI, with subsequent injury to the myocardial tissue, will produce ST segment elevations on the 12-lead ECG. Large ST elevation myocardial infarction, STEMI, will produce pathological Q waves hours to days following the acute process. 32. Therefore, a QMI represents a large MI. QMIs were formerly known as a transmural MI because they usually involve the full thickness of the ventricular wall. Conversely, an acute MI may be relatively smaller and not cause acute injury to the myocardial tissue. In this case, ST segments are not seen on the ECG, and the MI is called an NST-MI or an NQ-MI. An NQ-MI, formerly known as a non-transmural or subendocardial MI, does not involve the entire thickness of the myocardial wall, rather affects tissue primarily below the endocardium. Anatomical classifications for MIs are based on the surfaces of the left ventricle and not the anatomical heart. An anterior MI involves the anterior surface of the left ventricle. An inferior MI involves the inferior surface of the left ventricle, the diaphragmatic region. A lateral MI involves the lateral surface of the left ventricle. A septal MI involves the septum, and a posterior MI involves the left ventricle posterior wall. 33 MIs to different aspects of the ventricle result from compromised levels of blood flow within specific vessels. The CA supplies blood to the inferior and posterior aspects of the left ventricle and therefore is responsible for producing an inferior or posterior wall MI. The anterior and septal aspects of the left ventricle are perfused by the LAD, and therefore LAD occlusions are likely to produce anterior or septal MIs. The CX artery supplies blood to the lateral wall of the left ventricle and thereby produces a lateral infarction when it is occluded. The involvement of occlusion within specific vessels can be determined by a 12-lead ECG. 33 CA involvement is most likely depicted on leads 2, 3, and AVF. Augmented unipolar limb LAD. LAD pathology will be illustrated in chest leads V1, V2, V3, and V4, whereas CX pathology will most likely be demonstrated in lead I, AVL, V5, and V6. Figure 13.12. P495 electrical conduction abnormalities arrhythmias are any alteration in the electric conduction of the heart from the normal beat. They are caused by a disturbance in the electrical activity of the heart, resulting in impaired electrical impulse formation or conduction. 64 arrhythmias may present as benign or malignant, that is, life-threatening. Examples of malignant arrhythmias are sustained ventricular tachycardia, VTAC, and ventricular fibrillation, VFib. An example of a common benign arrhythmia in the elderly population would be atrial fibrillation, AFib, with a controlled ventricular response. This section will review a few conduction abnormalities and relevant implications for the physical therapists. Ectopic beats. A beat that originates from a site other than the sinus node is known as ectopic beat. The common ectopic beats are atrial, premature atrial contractions, PACs, and ventricular, premature ventricular contractions, PVCs. PVCs may occur either by themselves or in groups such as couplets, 2 PVCs, or triplets, 3 PVCs, or alternating with sinus beats such as bigeminy, every other beta PVC, or trigeminy, every third beta PVC. 0.64 APAC is an ectopic beat that originates in the atria and may present as an irregular rhythm. Figure 13.14b. It may be difficult to distinguish a PAC from a premature junctional contraction, EJC, an ectopic beat that originates within the area around the AV node. Usually, PACs or PJCs will not compromise CO, and physical therapy intervention may be appropriate if accompanied by adequate hemodynamic responses. The presence of ectopic beats results in an irregular rhythm. Usually, ectopic beats are transient, and their severity depends on their impact on company. It is certainly common to have a few PVCs even in a normal heart. Many people may have ectopic beats during times of stress or with stimulants such as nicotine and caffeine. Even though this may be a common response in a normal heart, it is important to educate patients with myocardial impairments who may have ectopic beats or irregular rhythms to avoid these aggravators. An increase in ectopy is undesired. It is unwise for any patient with cardiac disease to engage in exercise following recent cigarette smoking. Although the specific time frame a patient may be at risk for increased ectopy is not clearly known, a good rule of thumb may be abstinence of smoking for at least 2 hours either before or after exercise. Patient education on wellness strategies and smoking cessation is always useful for any patient identified as a smoker. Supraventricular ectopy. Supraventricular ectopy involves the rapid firing of an ectopic focus that originates in any location above the ventricles, atrial or junctional area. Examples of supraventricular ectopy include 1. Paroxysmal atrial tachycardia and 2. Supraventricular tachycardia. Sudden run-off PACs occurring at a fast rate, 100 to 200 bpm, is known as paroxysmal atrial tachycardia. PAT, a run-off either PACs or PJCs at a rate of 150 to 250 bpm is known as supraventricular tachycardia. STAT, Figure 13.14c. Patients with SVTAC usually respond to a carotid massage where stimulation of the baroreceptors within the carotid bodies of the carotid artery produce a parasympathetic response. Other treatment interventions to reduce heart rate for patients with SVTAC include coughing and breath holding techniques achieved through the Valsalva maneuver or carotid sinus massage. 64 of these techniques are geared to increase parasympathetic drive in different ways to reduce heart rate. Ventricular ectopy PVCs are ectopic beats that originate in the ventricle and may present as irregular rhythms. Two hallmark characteristics identify PVCs on the ECG. 1. A P wave is absent as the impulse originates in the ventricle and 2. A widened bizarre QRS complex signifying abnormal electrical conduction through the ventricle. Figure 13.14d. Single PVCs will not compromise CO of less than 7 per minute. Therefore, physical activity may be appropriate if accompanied by an adequate hemodynamic response. If the PVCs increase with activity, the activity should be stopped and the patient examined for possible signs of compromised cardiac output. PVCs may come from the same irritable site and are called unifocal PVCs. If they originate from different ectopic sites within the ventricle, they are known as multifocal PVCs. Fig 13.15a. Multifocal PVCs suggest a more irritable ventricle and are therefore more serious than unifocal PVCs. It is appropriate for the therapist to have the patient medically evaluated before beginning or continuing an activity. Finally, a rare type of PVC known as an errant PVC occurs when PVC fires very prematurely on the T wave of the preceding cardiac cycle. Figure 13.15b. These patients must be monitored closely because they are at an increased risk for developing a life-threatening dysrhythmia such as ventricular tachycardia or ventricular fibrillation. 64 and ventricular hegemony. Figure 13.14e. Every other beat is a PVC. Intrageminy. Every third beat is a PVC. Figure 13.14f. These rhythms occur transiently or episodically, and many patients have frequent bursts of these rhythms. If ectopy increases with activity, the activity should be immediately stopped. When two PVCs occur together, it is known as a couplet. Figure 13.14g. When three PVCs occur together, it is known as a triplet. Couplets and triplets are important in that they suggest a high level of ventricular irritability. Altered left ventricle function and ischemia are two of the more common causes for ventricular ectopy. Therefore, medical management is directed toward improved left ventricle function and perfusion whenever possible, as well as arrhythmia control. Physical therapy intervention is conservative at best and depends on the hemodynamic stability of the patient. Ventricular tachycardia, a run of 4 or more PVCs in a row, is known as VTAC. Figure 13.14h. VTAC may be either sustained or non-sustained. Sustained VTAC, by definition, occurs at an hour of at least 100 bpm and lasts for at least 30 seconds. The patient may or may not have a palpable pulse and, if present, the pulse will be weak. Because of the severe decrease in CO and rapid hemodynamic deterioration associated with this rhythm, the presence of sustained VTAC is considered an emergency. Medical intervention must be initiated as soon as possible. No physical therapy intervention is appropriate, except assisting the patient in stabilization, initiating cardiopulmonary resuscitation, CPR, when indicated, and activating the Advanced Cardiac Life Support, ACLS, system. VTAC may deteriorate quickly into VFib. Non-sustained VTAC occurs either in groups of 3 to 5 PVCs known as salvos, or a run of 6 or more PVCs lasting for up to 30 seconds. Non-sustained VTAC is considered a high-risk indicator for potentially lethal arrhythmias. Because the rhythm is non-sustained, the decrease in CO may not be sufficient to cause symptoms. However, until the etiology of the arrhythmia is identified and the rhythm controlled, physical therapy intervention is generally inappropriate. Ventricular fibrillation VFib is characterized by quivering of the ventricles resulting from inadequate electrical stimulation. The ECG demonstrates a sustained run of different-looking PVCs coming from different ectopic foci. Fig 13.14i. When the ventricles do not contract but rather quiver, there is ineffective company. The patient will arrest and expire if this rhythm is not altered immediately. The treatment of choice is activation of ACLS, including electrical defibrillation and medication. Patients who survive ventricular fibrillation through defibrillation become candidates for an indwelling defibrillator placement known as an automatic implantable cardiac defibrillator, AICD. Automatic implantable cardiac defibrillator. The automatic implantable cardiac defibrillator, AICD, is implanted in patients who have life-threatening ventricular arrhythmias, VTAC, VFib. 0.65. The AICD is programmed to deliver an electrical shock if it detects a HR higher than its programmed HR limit, 65. Therefore, it is important for the physical therapist to know this limit and avoid an exercise intensity that may inadvertently activate the device. In addition to knowing the HR settings for the patient with an AICD, there are other considerations. ST segment changes on the ECG may be common and are not specific for ischemia. Therefore, other diagnostic studies must be done. In addition, aerobic or strengthening exercises should be avoided initially after placement of the pacer to avoid inadvertently dislodging the device or the lead wires. Checking with the physician when these exercises may be included is prudent. There may be a danger for patients with AICDs or pacemakers from electromagnetic signals such as anti-theft devices, either causing the AICD to discharge or causing pacers to slow down or speed up. It may be no problem for patients to walk through these devices, but lingering within a few feet could be dangerous. Atrial fibrillation. Atrial fibrillation, AFib, is characterized by quivering of the atria due to inadequate electrical stimulation. A varied number of non-sinus originating P waves, known as fibrillatory waves, exist for each QRS complex. Figure 13.14a. The ventricular rhythm is said to be irregular because there is no regularity to the irregularity of the ventricular rhythm. It is important to note that effective contraction of the atria accounts for approximately 15% to 20% of CO. The atrial kick, 66 in patients with abnormal electrical conduction causing a quivering of the atria, AFib. The mechanical contractile ability of the atria is reduced, resulting in a low atrial kick and compromised CO. 66 patients may exhibit AFib continuously as their baseline rhythm or go in and out of this rhythm at rest or with activity. Physical therapy intervention may be appropriate for patients in AFib who have a good ventricular rate that rests, with appropriate hemodynamic and HR increase with exercise. In patients with AFib and rapid ventricular rates, greater than 120 bpm, at rest, exercise intensity must be lowered, and hemodynamic response is monitored carefully. This is because a rapid ventricular rate in addition to the loss of atrial kick further compromises the CO and results in altered hemodynamic responses. A good rule of thumb is to avoid physical activity and seek medical consultation if the patient's resting HR is greater than 115 bpm, if the patient appears uncomfortable, or if there is an inadequate hemodynamic response. Because this rhythm is irregular, it is important to monitor the HR for a full minute rather than 15 to 30 seconds to obtain an accurate pulse rate. Conduction delays and blocks changes in the length of the PR interval, the width of the QRS complex, and the length of the QT interval are some of the ECG measurements indicative of conduction abnormalities. 67 conduction delays through the AV node are classified as first, second, or third degree heart blocks. First-degree heart block occurs when the conduction time through the AV node is prolonged. Therefore, the ECG will have an increased length of the PR interval. Figure 13.15c.67. There are two categories of second-degree heart block: Mobitz type I and Mobitz type II. Each is hallmarked by the presence of dropped beats. Mobitz I, also known as Wencker-Batch, presents with a gradual increase in PR interval length in the preceding beats and then an eventual dropped beat. Figure 13.15d. Mobitz II has normal PR intervals in all the beats preceding the dropped beat. Figure 13.15e.67. In third-degree heart block, a mismatch of atrial and ventricular conduction exists, so there is no consistency between the atrial contraction and the ventricular contraction, that is, no relationship between P waves and QRS complex on the ECG. Fig 13.15f.67. Patients in first-degree block have no limitations to exercise. Whether or not exercise is permitted with second and third-degree blocks depends on the etiology and subsequent hemodynamic responses. Medical clearance is warranted before beginning any exercise. Conduction delays through the bundle office are known as either right bundle branch block, RBBB, or left bundle branch block, LBBB. 0.67 bundle branch blocks are not true arrhythmias because there is no change in the actual rhythm, just in the timing of conduction through the bundle office. The heart is still depolarized from the same pacemaker, only the route of activation is changed. Bundle branch blocks present on the ECG is a distortion of the QRS complex with an increased duration, that is, widening, figure 13.15g. The presence of an LBBB on the ECG is usually permanent and indicates a pathological condition. RBBB may occur from a variety of reasons. It may be a permanent change due to underlying disease, or it may be benign. RBBB can also occur transiently. LBBB usually indicates the presence of more significant disease than a BBB. The presence of a new bundle branch block should be medically evaluated before beginning or progressing an exercise program. Following medical clearance, there is usually no contraindication to exercise in either the BBB or LBBB population. Because of the alteration of the QRS complex and as a result the ST segment, the sensitivity of the ECG in detecting ischemia via ST depression is lost in the patient with LBBB. Further, during exercise a fast left bundle branch cannot be distinguished from ventricular tachycardia. 64 In such cases, patients with a left bundle branch block do not undergo exercise stress tests. Rather undergo chemical stress tests to stress the heart. 64.
All right. Wow.
Now this graph illustrates the relationship between cardiac markers, that is markers of myocardial necrosis, with the components or the stages of the acute coronary syndrome. So acute coronary syndrome can be unstable angina. The next category is it can be non-STEMI, non-ST elevation myocardial infarction. And the third and most serious component of the acute coronary syndrome is STEMI, ST elevation myocardial infarction. So what changes would we expect to see with troponins in these conditions and with creatine kinase? Well, both of these are cardiac markers, and increased levels of them indicate myocardial necrosis. It indicates that some myocytes have died, presumably as a result of the infarction. Now, creatine kinase isn't used as commonly these days because creatine kinase can actually be released from any damaged muscle. If you want to be certain it's from the myocardium, you have to do a specific isoenzyme analysis. But it will rise with increasing myocardial damage. The more myocardial cells die, the more the creatine kinase will be raised. So the idea is with creatine kinase and troponins that they're not raised in unstable angina because this is not associated with myocardial necrosis. It's a component of the acute coronary syndrome because it's caused by vascular occlusive pathology, but it's not associated with significant or really technically any myocardial necrosis. So the troponins are not raised in unstable angina. The patient can still have all the clinical features of acute coronary syndrome, but they won't have ST elevation, they won't have positive troponins. It's the troponin negative acute coronary syndrome. But then if there's a non-STEMI, then there's enough coronary thrombosis to cause myocardial infarction, and myocytes will start to die. And the more severe the condition, the higher the levels of troponin, the greater the mortality. So the higher the levels of troponin, the greater the levels of mortality that we can expect to unfortunately see in our patients. So the levels of troponin go up through increasing stages of severity in non-STEMI. But then we get even higher levels with STEMI. And of course in STEMI we're going to get the ST elevation as well, but increasing levels. And the greater the amount of myocardium that is infarcted, the higher the levels of troponin that we're going to see. So troponins are a very useful test. The cardiac specific troponins are troponins T or I. They are cardiospecific. And we would expect troponins to start rising probably about 3 hours after a myocardial infarction, 3 to 12 hours. It actually depends how sensitive your equipment is. wherever you're working, but would normally say they rise within 3 to 12 hours after MI. So if we can do baseline amounts of troponin straight away, then more troponins a few hours later, it's going to give us some indication of troponin increase. The peak levels are at 24 to 48 hours after an acute infarction, and then they slowly start to tail off after about 72 hours. They'll tail off slowly over a few days. And they're positively correlated with the amount of myocardial necrosis and mortality. Now, physiologically, what they do is they're associated with the actin myofilaments. You might remember that actin is the thin filament and myosin is the thick filament. And in relaxed muscle, the troponins actually work by preventing cross-bridging with the myosin microfilaments, thereby preventing contraction of the muscle. But during depolarization, there's increased levels of calcium, and the increased levels of intracellular calcium, the increased levels of calcium in the cell inhibit the troponins, allowing cross-bridging between the actin and the myosin, and therefore cardiac contraction. So if we think about the actin as being the thin filaments here, and the myosin as being the thicker filaments, it's the cross-bridging between these filaments that cause the contraction. So when the muscle contracts, cross-bridging draws the two together, and the actin and myosin slide together. So the troponin is associated with the actin to prevent that happening inappropriately. And of course, these are microfilaments. They're all inside myocytes. They're inside the cells, all these filaments. With their associated troponin associated with the actin thin filaments. So here's the troponins in here associated with the actin. And if this cell dies, the membrane will be disrupted and no longer able to contain the troponins inside the cell. So the troponins will leak out into the blood through the dead cell membrane, where we will detect them with our biochemical tests.
Cool. I like it.
My experience.
Okay, so this is figure 13.6. It's a representation of the heart in normal cardiac electrical activity. An ECG is the body surface manifestation of the depolarization and repolarization waves of the heart. P wave is generated by atrial depolarization, the QRS by ventricular muscle depolarization, and the T wave by ventricular repolarization. The PR interval is a measure of conduction time from atrium to ventricle. The QRS duration indicates the time required for all of the ventricular cells to be activated. QRS. The QT interval reflects the duration of the ventricular action potential. So the P starts here in the SA node. The P wave is generated by atrial depolarization. This is the atrium. The orange is atrial depolarization. And it goes to the little red, which is the AV node. QRS by ventricular muscle depolarization. So QRS, so QRS all in here. So the red to the purple is ventricular muscle depolarization. The T wave, where it gets lighter purple here and lighter purple here, is by ventricular repolarization. So the dark purple here is ventricular muscle depolarization, and then the lighter purple here is T wave by ventricular repolarization. ER, so from here into the dark purple, is the measure of conduction time from atrium to ventricle. The PR interval is a measure of conduction time from atrium to the ventricle. PR. The QRS duration indicates the time required for all of the ventricular cells to be activated. So QRS. So basically QRS. QRS. Oops. The time required for all of the ventricular cells to be activated. The QT interval reflects the duration of the ventricular action potential. QT. Okay. Then we have table 13.2, laboratory test and reference values, and some of the reading highlighted a few of those. Electrolyte levels are also important to consider before treating patients with heart disease. Appropriate levels of potassium, calcium, and magnesium allow for normal electrical conduction through the heart. And just kind of think of your finger, MCP. Control. I put it in here somewhere. I don't know where it went though. Okay, so potassium, calcium, and magnesium. Little cell. Your MCP. That's how I'm going to remember it. Magnesium, calcium, potassium. Okay, so hypokalemia is low potassium. If you look over here, less than 3.5. Less than 3.5. Produces arrhythmias with flattened T waves and depressed ST segments, as well as bilateral lower extremity muscle cramping. Flattened T waves and depressed ST segments. Okay, so let me pause this for us. Okay, so hypokalemia, which is low potassium, is going to produce a flattened T wave. So this wave right here is going to be flat, and a depressed ST segment. Depressed ST segment. Okay, so let's look at this beautiful picture I found. So normal kalemia is going to have a normal T wave, rounded, normal sized T wave. And let's see the ST segment depression. Interesting, look at the difference. So hypokalemia is going to have flattened T waves and depressed ST segments. Okay, so moving on to hypocalcemia, which is low blood serum calcium levels, and hypomagnesia, low magnesium in the blood, have a potential of increasing ventricular ectopy. Within the heart. Ectopic beats is a beat that originates from a site other than the sinus node. Common ectopic beats are PACs and PVCs. Premature atrial contractions of PAC, and ventricular, which is premature ventricular contraction. So if your patient has hypocalcemia or hypomagnesium, they could have an ectopic beat in the heart. Increases the potential. Calcium levels, normal lab levels, are 9 to 11, and magnesium normal is 1.5 to 2.5. Calcium 9 to 11. You can think of calcium 9-11. That could be an emergency if you don't have good calcium levels. 9-11. Magnesium 1.5 to 2.5. 1.5 to 2.5. And again, potassium was hypokalemia, less than 3.5. Flattened T waves and depressed ST segments. And hypocalcemia and hypomagnesia. You can have ectopic. Okay, a couple more slides, and then the ECGs I'm going to do in a totally different video. It's like a whole nother day. I'm going to do that tomorrow in the morning. Box 13.1, indications of exercise intolerance that warrant modification or termination of an exercise session. Signs and symptoms of moderately severe or increasing angina, marked dizziness, lightheadedness, or ataxia, cyanosis or pallor, which is pale, blue or pale, excessive fatigue, leg cramps, or claudication. Other abnormal responses is failure of the systolic pressure to rise as exercise continues. That's the top number. Pressure in your heart when your heart contracts. A hypertensive blood pressure response, including a systolic pressure of greater than 200 or a diastolic pressure greater than 110. So 200 over 110 is this, okay, let's stop this. A progressive fall in systolic pressure of more than 10 to 15. So that's your top number falling, dropping 10 to 15. And a significant change in cardiac rhythm detected either by palpation or by ECG monitoring. Arrhythmias, ST, T wave changes. Figure 13.9 talked about the evaluation triad for patients with acute coronary syndrome. You're going to look at the complaints the patient has. You're going to look at the cardiac enzymes, and you're going to look at their ECG. And we already talked about the cardiac enzymes briefly. Yep. And we watched the video, that doctor, kind of like that. But he was talking about creatine kinase, and he was talking about troponin. But the ones he didn't talk about was lactate dehydrogenase the LDH, and the myoglobin. Okay, so the creatine kinase, like we heard in the reading and what the doctor talked about, was that your creatine kinase is going to go up not only when you have cardiac muscle dysfunction, but also if you have muscle injury. There's other pathologies or incidents that can cause the creatine kinase enzyme to go up. So for a minor cardiac dysfunction, it would be 5%, and for a major cardiac dysfunction, it would be 10%. Normal level is 0 to 3%, and peak levels 14 to 36 hours. So over 12 hours and up to, what is that, a day and a half? Yeah, day and a half. Lactate dehydrogenase normal levels is 100 to 225. Okay. Minor cardiac dysfunction, it would go up to 300 to 750, and then a major cardiac dysfunction would be greater than 1,000. Troponin 0 to 0.2 is normal. Minor cardiac dysfunction would be 5, and then major cardiac dysfunction would be greater than 10, and peak hours are around 2 to 3 days. Actually, that would be 1 to 2 days. Correction. So 1 to 1.5 days, 24 hours to 36 hours. Myoglobin, normal is less than 100. Minor cardiac dysfunction is going to be 200, and then major cardiac dysfunction is greater than 500. Okay. About that. Okay. Unusual distribution of pain with myocardial ischemias. Patient often reports an intense pressure like an elephant sitting on the chest. Further angina may be present as a referred pain due to involvement of the neuroreflex pathway via the thoracic and cervical nerves. This results in chest pain not being felt in a specific spot, but usually as a diffuse discomfort that may be difficult to localize. It may radiate to anywhere in the upper extremities or thorax, most specifically to the left arm and left jaw. This picture shows common areas for referred patterns of chest pain. Hallmark approach to differentially diagnosing ischemic chest pain from non-ischemic chest pain is to observe for accompanying signs and symptoms of compromised cardiac output. These signs include dizziness, lightheadedness, weakness, diaphoresis, which is sweating, and fatigue. I don't know why the book said weakness twice, but it did. I copied this straight from the book, but it says weakness twice. Thus, cardiac chest pain during ischemia or an infarction will be accompanied by signs of compromised cardiac output. But chest pain from other etiologies, including pulmonary chest pain, pleural pain, gastrointestinal-related chest pain, or musculoskeletal pain in the thorax, will not precipitate the classic signs and symptoms of compromised cardiac output. So, if the patient is having radiating pain from the upper extremities, the thorax, through the left arm, on the left jaw, but they also have dizziness, lightheadedness, weakness, diaphoresis, and fatigue, you probably want to call 911. Okay, so let's see, we already talked about that one. Effects of medications on heart rate, blood pressure, ECG, and exercise capacity. Beta blockers. are going to decrease heart rate, decrease blood pressure, decrease on an ECG, decrease heart rate, decrease ischemia, increase capacity, exercise capacity in patients with angina, but decrease or not change in patients without angina. Nitrates is going to increase heart rate or no effect. Oh, at rest. Okay, I see. Nitrates is going to increase heart rate at rest, increase or no effect with exercise. So nitrates is going to increase heart rate at rest, increase or no effect during exercise. With blood pressure, it's going to decrease blood pressure at rest, and it's going to decrease or not affect blood pressure with exercise. On the ECG, it's going to show an increased heart rate at rest, increase or no effect of the heart rate with exercise, or decrease ischemia, may prevent or delay myocardial ischemia. Okay. Exercise capacity, increase in patients with angina. It's going to have no effect in patients without angina, no effect in patients with congestive heart failure. Calcium channel blockers. Calcium channel blockers. Looks like nicardipine is going to decrease heart rate or not change at rest and with exercise. It's going to decrease blood pressure at rest and with exercise. Verapamil is going to decrease at rest and with exercise. Diltiazem. I don't know how to say these stupid medications. Decrease heart rate at rest and with exercise on an ECG. Wow. So calcium channel blockers are going to increase exercise capacity in patients with angina, and it's going to have no effect on patients without angina. Digitalis. The heart rate is going to decrease in patients with atrial fib and possibly chronic heart failure, congestive heart failure, not significantly altered in patients with sinus rhythm. It's going to have no effect on the blood pressure at rest and with exercise. It may produce non-specific ST wave changes at rest, may produce ST segment depression with exercise. Exercise capacity is improved only in patients with atrial fibrillation or in patients with CHF, congestive heart failure. Diuretics are going to have no effect on heart rate at rest and with exercise. Diuretics are not going to change blood pressure, or it's going to decrease blood pressure at rest and with exercise. ECG is going to have no effect on the ECG or PVCs at rest. May cause PVCs and false positive test results if hypokalemia occurs. low potassium. May cause PVCs if hypomagnesia occurs. So we remember what PVCs are, right? Let's just do this. Okay. So a PVC is a premature ventricular contraction. So a diuretic may have no effect, or they will have PVCs at rest. May cause PVCs or false positive test results if hypokalemia occurs. May cause PVCs if hypomagnesia occurs. So it's not just it's this one too. What are you doing? There you go. Hypokalemia. May cause PVCs and false positive results if hypokalemia occurs. May cause PVCs if hypomagnesia occurs. That's diuretics. Exercise capacity will have no effect on exercise capacity except possibly with patients with CHF. Vasodilators, ACE inhibitors, and angiotensin II blockers. Oh my God. Please hold. Okay. Vasodilators are going to increase heart rate or have no change, no effect at rest and with exercise. Vasodilators are going to decrease blood pressure at rest and with exercise. On an ECG, vasodilators are going to increase or have no effect on heart rate at rest and with exercise. Exercise capacity is not going to change except to possibly increase or no change in patients with CHF. ACE inhibitors and angiotensin II blockers. Heart rate is not going to change, no effect at rest and with exercise. Blood pressure is going to decrease at rest and with exercise, and have no effect on an ECG at rest and with exercise. No effect with exercise capacity. There'll be no effect except possibly increase or no effect in patients with CHF. Alpha adrenergic blockers. No effect at rest and with exercise. Blood pressure will decrease at rest and during exercise. Will have no effect on the ECG at rest or with exercise and no effect on exercise capacity. Anti-adrenergic agents without selective blockage will decrease heart rate or no effect at rest and during exercise, will decrease blood pressure at rest and during exercise, heart rate will be decreased at rest and during exercise or no effect, and will have no effect on exercise capacity. Nicotine is going to increase heart rate or no effect on heart rate during rest and with exercise, will increase blood pressure at rest and during exercise, will increase or have no effect on heart rate, may provoke ischemia and arrhythmias at rest and during exercise, will have no change on exercise capacity except possibly decrease or no effect in patients with angina. Definitely going to have to do repetition on those slides for sure. Okay, the J point, the point where the S wave turns into the ST segment. The J point, right here. Measurement of ST segment elevation and ST segment depression in most instances. The point of reference for interpreting the ST segment, the J point. If ischemia is present, the ST segment will be depressed one or two small boxes at two small boxes beyond the J point. And the T wave may also be inverted, flipped. Ischemic changes will be present only while the ischemia is present. When the ischemia has resolved, the ECG will return to normal. Okay, this is the last slide we're going to do on this particular reading video. The next video is going to go into detail these slides as well as pull these slides, and then I'm going to pull in lecture stuff from school on the next video. I got to be in the mood for that, but okay. Causes of cardiac muscle dysfunction. Hypertension, increased peripheral artery pressure contributes to increased afterload and pathological hypertrophy of the left ventricle. Coronary artery disease, acute injury to myocardial tissue damages ventricular contractility, causing systolic dysfunction. Scar formation seen in infarcting tissue alters relaxation and may lead to the diastolic function. Cardiac dysrhythmias. Normal electrical conduction through the heart allows for normal mechanical contraction of the ventricles. Altered electrical conduction alters the mechanical activity of the ventricles, exacerbating heart failure. Valve abnormalities. Cardiac valve pathology, stenosis or regurgitation causes structural changes to the chamber behind the valve, resulting in cardiac muscle dysfunction and failure. Pericardial pericarditis, fluid in the pericardial space with resultant cardiac tamponade, compresses the ventricles, leading to cardiac muscle dysfunction and heart failure. Cardiomyopathies, damage to the myocardial cells from previous pathological processes, alters the systolic and or diastolic function of the ventricles. And we are going to stop there.